afternoon. Our 3-day session is coming to a wind down pretty soon, and I'm very excited to be introducing our guest speakers for this session on PEGs, vents, and trachs. Today we'll have Dr. Norm Harrell, who's a staff physician at the James J. Peters VA Medical Center in the Bronx, and an associate professor of neurology and rehabilitation at Mount Sinai Medical Center in Manhattan. Besides seeing veterans at the ALS Center at the VA, he conducts clinical research on electrical stimulation for spinal cord injury, ALS, and other disorders. Along with Noam, we have Natalie Sutcliffe, a supervisory speech-language pathologist at the James J. Peters VA Medical Center. Ms. Sutcliffe has over 30 years' experience in the field of speech-language pathology, with a special interest in working with veterans with ALS, and also veterans with head and neck cancer and aphasia. Thank you both for joining us today to share your experience on these very important topics for our patients throughout our entire region, not just our veterans. Welcome, and Noam, you can begin.
Great, thank you, Teresa.
Let me just add one quick thing. Sorry, if folks want to ask questions throughout the presentation, you can type your questions into the Q&A chat box, and we'll be taking those throughout our session. Thank you so much.
Thank you. Yeah, we'd like to make this as interactive as possible, and we hope and expect a lot of questions. We're here to try to answer them. We're here to discuss things that happen along the course of the disease, including options of feeding tubes, tracheostomy, with or without ventilation. Okay, so let's just start with a little story first, a vignette. Mr. G is a 51-year-old Desert Storm veteran, developed symptoms of ALS 2 years ago. And he's now dependent on a walker and wheelchair, depending on how long he needs to ambulate for. He's starting to have some difficulty swallowing, and the difficulty is worse when he's trying to drink fluids or swallow his pills. Tends to cough a little bit. He's also noticing he's having trouble sleeping, because every time he lies down, a few minutes later, he just doesn't feel comfortable lying flat. So he's found that he ends up sleeping better in his recliner in the living room. Oh, this may sound like a common scenario. So the question is, what next? And that's what we're basically going to be talking about. Okay. And we know everyone looks this up when they get the unfortunate news of the diagnosis of ALS. And this is the number, these are the numbers that are out there on Google. The average, and I put that in quotation marks, is 2 to 5 years survival. And I can guarantee you here at the VA, and I think elsewhere, we see many, many, many patients with ALS who live much longer than this, quote, average time. So it's impossible to predict in any one person how short or how long the disease will last. So we need to consider things that can happen over the longer term. So we see this all the time. So we routinely see patients with ALS who have had the diagnosis for more than 10 years. And because we follow people for a long time here at the Bronx VA, it's very, very important. And I know you guys have already had talks on treatments, et cetera. So that's not what we're going to focus on here. We're going to talk about the other things, including nutrition. Okay, so these are facts. These are proven facts. Better nutrition leads to longer survival in ALS, and not just longer survival, but it increases the quality of life. Okay, and again, why is this so important? Because once you have difficulty swallowing, which is also known as dysphagia, I should point out, it's a little bit counterintuitive, but when you have trouble swallowing from ALS or from any other neurological problem, it's usually worse for liquids than it is for solids. And pills, which you're trying to take with liquids, are also very hard to get all the way down. Okay, so that's the type of swallowing difficulty you have in ALS. And Natalie, this is her expertise, but you have a risk of aspirating or food going down the wrong pipe and causing pneumonia. Natalie, do you want to?
Yeah, so just as Dr. Harrell said, so the goal when we swallow is to safely swallow. That's to prevent any food or liquid from going down the wrong pipe. or ending up in your lungs. And so people with ALS can have difficulty swallowing, as Dr. Harrell pointed out. And if that happens over a period of time and the food and liquid is going down the wrong pipe, and I'll show you exactly what that means in a couple of slides, it can cause a pneumonia in the lungs. But as Dr. L mentioned, it's usually worse with liquids and with pills, but a lot of our patients also complain of difficulty swallowing solids. So it really can be with any consistency.
And, so we're not just talking about nutrition, we're talking about safety of getting that nutrition. When the swallowing apparatus is not functioning perfectly, we have a high risk of inhaling food down the wrong pipe and getting into the lungs, causing pneumonia. Okay, and also, obviously, if you don't eat enough, you will start to lose weight. And what happens is, as you develop more trouble swallowing, more dysphagia, along with some trouble breathing, which we'll get to, you start having trouble eating and taking enough supplements to keep your calorie count and your protein count high enough. So you feel this pressure. This probably sounds familiar to many of you out there. You feel this pressure to eat and drink enough food and supplements, otherwise you continue to lose weight. And when you lose weight, that contributes to your muscle atrophy, the shrinking of the muscles, and it also contributes to a weaker immune system because protein, your muscles and your immune system are made out of protein, essentially. So you need to take in enough protein to keep the muscles and your immune system as strong as they possibly can be. Okay, this is not going to reverse the process, unfortunately, but it can help slow down the process. And again, we can't see actually, maybe we can see the questions. That's a great question from an anonymous attendee. Now, I don't know if you can see it, but it says, should I think about getting a feeding tube even if I'm swallowing okay? We're definitely about to talk about that.
We are. That's a great question. And no, for some reason, I can't see the questions, but I probably can pop it
If you
up.
hover your mouse over the screen, it hopefully will bring up a Q&A thing and then click on that.
Like I said, I'll go ahead and be fielding you all the questions so you don't have to worry about them.
Okay, great. So what we have here, and I don't know if you guys in the audience can see my cursor, but this is kind of a drawing of how we swallow. So just for kind of orientation's sake, the green that you see in A and in B, C, D, E, and F, make believe that's applesauce. Because as speech pathologists, we love to give our patients applesauce, okay? So Noam is highlighting that green. So what we wanna make sure is that the green is going down the right pipe. And Noam, on slide E, if you could just put your cursor on the green. So that's going down the food pipe. To the left of that green is your airway and your vocal cords right there. And we do not want the food or liquid to go down there because when that happens, it's called aspiration, which we already mentioned, and that goes directly into your lungs and can cause pneumonia. So as Dr. Harrell and I said, first and foremost, when we're eating by mouth for anybody, whether you have the diagnosis of ALS or not, the goal is safe swallowing and to make sure it's going down the right pipe. So this kind of just shows a drawing of how that happens. All right, so there's a lot that goes into swallowing. It's something we don't really think about until we have a little bit of an issue. All right, and the most common complaint that I get from our veterans with swallowing problems is, Noam, if you go to slide D and just point to where the green is, of complaints of food getting stuck, and sometimes it gets stuck there, okay? So that's one complaint of some of my patients with ALS. Another complaint is that I cough when I drink liquids or I eat something. Coughing is good. Coughing is a reflex. It protects our airway. So I like it when my guys say, yeah, sometimes I cough, because it means your body is responding appropriately if something might be going down the wrong pipe. And so by coughing, you're kind of bringing that food kind of out of the airway and back up into the throat. Okay. All right, we can go to the next slide. So, how do we maximize nutrition and safety? Okay, so, and we'll get to the person's question about the feeding tube if you're still eating by mouth in a moment. So, sometimes people with ALS have difficulty bringing the food to their mouth, have difficulty holding the cup to drink it. So we work very closely with our team members in occupational therapy and physical therapy and provide adaptive spoons, forks, cups that are made so it's a little easier for the person to grip and to bring up to their mouth. Because a person might be able to swallow just fine, but they might have difficulty bringing the food or the liquid to their mouth. So that's all kind of under the umbrella of swallowing, but that's more of a feeding issue. And that sometimes happens with our patients with ALS. They can swallow fine, but they have such upper extremity weakness that it's very difficult for them to bring the spoon or the cup to their mouth. So we work closely with OT and PT to come up with ways to modify the spoon, the fork, the cup to make it a little easier. Another thing that we can do is thicken the liquids. All right. So as Dr. Harrell mentioned, when he said it was kind of counterintuitive when we said, oh, some people have difficulty swallowing liquids, you would think, well, that's the easiest thing to swallow because I don't have to chew it. I don't have to move it around in my mouth. It just goes down really fast. Well, that can be a little bit of an issue. If it goes down too fast and the person can't control the flow of it, it can very easily go down the wrong pipe. So sometimes by thickening the liquid, and here at the VA, we use something called Simply Thick. It's a gel that thickens water, coffee, juice, anything to different levels of thickness. But in drugstores, you can get something called Thicket. You can also get, I think it's called Thicken Up, or Thicken Easy. Sorry, not Thicken Up, Thicken Easy is another thing. So those are things that you can add to liquids to make it a little easier to swallow because it gives you a little more, sorry, Dr. Harrell's spelling. So it's thick and easy, like, and that was easy.
I'm going to take a second here. We have a great question that sort of fits in with what you're talking about, especially about speed of something going down. Okay. So are straws dangerous for ALS patients?
Wow, excellent question. Excellent question. And as with any question, there are always multiple answers. And so the first answer I'm going to give, it really depends on the individual. So for some of my patients, absolutely, straw is an easier way for them to swallow. For other patients, I will say, no, you can't use a straw. So when you're using a straw, it helps because it kind of puts the liquid into your mouth in kind of a controlled manner and kind of gets it to the back of the mouth. But in order to do that, you have to draw up on that straw. So you have to breathe in to get that liquid up that straw. So if you're having breathing problems, that could be a little bit of a challenge. And sometimes when people draw up on a straw, they're holding their breath and then they're like, okay, so what do I do? And they try and swallow, and sometimes it goes down the wrong pipe and sometimes it doesn't. So to answer your question, sometimes a straw can be helpful, other times not so much. And again, we're going to mention working with the team. So when you have the diagnosis of ALS, hopefully you'll be seeing a speech therapist, again, or speech pathologist, as we're formally called, just to evaluate how you're doing with the speaking, how you're doing with the swallowing. You'll be working with a dietitian or a nutritionist. You'll be working with an occupational therapist and a physical therapist. So we kind of make these decisions as a group. So yeah, sometimes the straw can be helpful, sometimes it can't. So So thickened fluids, like I said, can help because it gives you a little bit more control. If I poured water on the table, what would happen? The water would spread very quickly and would run off very quickly. But if I put something a little thicker on the table, like applesauce or like a thickened liquid, it won't move as quickly. So because it doesn't move as quickly, it gives your muscles a chance to respond and act more appropriately to make sure that the food or liquid goes down the right pipe. All right. Another way we can maximize nutrition if a person has difficulties swallowing, especially with more solid, dry, dense foods, is we might recommend pureeing the solids. And everybody says, oh, I don't want to eat baby food or whatever. It's not. You can take regular food and you can put it in a blender, you can put it in a bullet, and it just gets it to a consistency where it's a little thicker, it's smooth, and for some people, not all, for some people, it makes it a little easier to swallow. Because the second thing of nutrition and swallowing is, like I said, number one, to swallow safely, and number two, to make sure, as our slide says, we're maximizing the nutritional support. We're maximizing the calories that you are taking in, because we don't want our patients with ALS to lose weight. We want them to be able to maintain weight. And so that's why the dietitian would recommend things like high protein foods, possibly nutritional supplements like Ensure, like Glucerna, like Boost, to be used in addition to the regular foods and liquids that you're eating, but will give you a little extra calories and a little boost in your nutrition. And that brings us to feeding tubes.
Just to add a couple of comments there, we don't want you to lose weight. And remember, protein is needed for your muscles and for your immune system to make all those antibodies that fight off infections. So we need to get protein. And the word supplements here is very important. We'll talk about supplements. There are many different flavors out there, but we're very well aware. Not everyone really wants to just have supplements. You want to have your favorite food also, and we'll talk about that. We're about to get into that. And one other thing I want to comment on about pureed solids is if you have trouble cutting your food, that's one other kind of side advantage, pureeing it in advance. It's not just for swallowing. It takes out the need to cut your food as well. And I can't help noticing the questions because I'm OCD. So we're about to get to that second question as well. Sadia, thank you. Okay, oops. Okay. And hopefully we can get some interaction here because we assume some people in the audience right now have feeding tubes. So why feeding tube? And again, it's to reduce that potential hazard of food and liquids going down the wrong pipe, as we just discussed. And it's to maintain not just body weight, by the way, hydration. If you're dehydrated, you're going to feel weak. You're going to feel dizzy. We need to maintain hydration. And that can be hard if you have trouble swallowing. So the feeding tube, even if you're eating everything else, might be able to be used as a supplement for hydration. And this all reduces the pressure that you feel to try to finish your meals. How many caregivers and spouses are kind of nagging you to finish your meals? This can help reduce the pressure. Having a feeding tube, and we'll say this multiple times, does not mean that you have to stop eating by mouth. You can continue to eat by mouth, but this can help relieve the pressure of eating every single calorie you need. And again, these are facts. There are many studies that show not just that feeding tubes prolong survival, very importantly, they improve quality of life. And I hope we can get some interaction here. I know it's through the chat, but people who have had their feeding tubes already placed, we haven't met anyone that regrets it. So I'd like to hear that. There's always an exception. So we'd like to hear it if you do regret it. So please.
And just to piggyback on what Dr. Rill said, our goal, again, as we keep saying, is to swallow safely and to maintain that optimal nutrition. And so, yes, You can have a feeding tube, and yes, you can still eat by mouth. You would need an evaluation by a speech pathologist to make sure that it's safe for you to eat by mouth and what foods and liquids would be the safest for you. But many, sorry, but sorry, I can't talk.
We're in the hospital, folks. Sorry about that.
Yeah, sorry about that. So many of our patients do have the feeding tube, use it, but then they're also able to have some foods and liquids by mouth. And that's a good thing. That's a good thing because you always want to use those muscles, because the muscles in our throat are used both for speech and swallowing, and you want to keep them flexible and functional as possible.
I'll also add one of the first things Dr. Harrell said was that swallowing medications becomes very difficult for patients. And this is an easy access, no more swallowing of those pills. You can put them down the tube.
That's right. Very good point, Teresa. Yes.
And maybe we can address the question about, does a feeding tube accept only formula or, real Parmesan?
So good question. Good question. It depends on the type of feeding tube, but you absolutely can put other foods and liquids through the feeding tube besides the nutritional supplements besides the tube feeding. So Ensure, Glucerna, any of those can go through the feeding tube. Water, obviously, people also put juice. The feeding tube is not very big, so it would have to be in that liquid form to go through. But yes, I've had patients put, like I said, the juice. Water absolutely goes through the feeding tube. They've put coffee through the feeding tube. So it really depends. But again, this is why we advocate working together as a team, because the dietitian is the subject matter expert on what goes in a feeding tube. And then the dietitian would work with me, the speech therapist, and we'd work with the doctor, like Dr. Harrell, to make sure that everything is appropriate. But yes, you can put other things through the feeding tube.
I'm going to advise no Coca-Cola. Coca-Cola can destroy the balloon that's
Yes.
holding the tube in place and the bottom end of the tube. So that's one thing we always say, never to put down the tube.
Right.
And
That's a question. Is that brand specific, or brown sodas, or?
Coca-Cola is the worst, but we do see that Pepsi is a problem as well.
And I would also think carbonated beverages in general, Teresa, might be a little bit of a challenge because it might add to producing gas and things like that. And just
then we
might
just
make
open
it,
the tube and let the gas come out.
Yeah,
Because
that's true.
Sometimes
true.
if the tube gets sluggish because maybe medication is stuck, we will tell them to put clear sodas down, ginger ale, 7-Up,
Yep.
Coke, club soda. But if they do have too much gas, that's another thing that some people do have a problem with gas, and they love the tube because they can open the tube and let the gas out.
Absolutely, yes.
Okay, so one other point. Now there's 2 points, so we'll get to Sadia's second question. One point is, if you do blend up your food and put it in the tube, one drawback is you will not be tasting it. So it's not really a route for your favorite foods to go in. Favorite foods you will try to have by mouth so you can taste it, but it's to get all the extra calories and protein and hydration. That's what you want it going into the tube. And I don't know the answer, but the question from Sadia is, I've heard that not all kinds of blenders are appropriate for blending food up to go into the feeding tube. Which ones work best?
Good question. And I don't know, because again, depending on the diameter of the feeding tube, and Teresa, you probably know better than I, the food that's blenderized really has to be fairly liquid to go through the tube, because you don't want the tube to get clogged or blocked. So in terms of type of blender, I would think one that would be pretty powerful and to really pulverize and make it into a more liquid form.
Right, not to use brand names, but the bullet type thing that does make things as liquid as possible is the best. And the one thing is, you know, you have to add a lot of water or other liquids. And a lot of people use like a broth to add to the food to thin it out, but the broth could be very salty. So just to have that, like Dr. Harrell said, you're not tasting the food. It doesn't necessarily make it a better quality meal for the patient. You know, if you want to put some stuff in the mouth, even to taste and not be able to swallow while you're putting the formula down, it works. For a lot of people do that, and because the family's blending the whole meal to pulverize it to make it so small to go down is a lot of extra work. Some people do it no problem at all, but you just have to remember the liquid is a very important part, and just make sure it's not too salty.
Right, right. That hydration and making sure that you're flushing the tube and getting plenty of water is very important.
And this is one of the great features of getting together like this, and we try to do this at the VA as well, having support groups. Patients and caregivers can talk to each other. So someone has suggested the Ninja Smoothie Maker. This is not an official government statement coming from me right now, but I'm just relaying the comments. Someone has suggested the Ninja Smoothie Maker. Sounds good. Okay, one other thing, and we're going to emphasize this. If you look at these two pictures, both of these men have their shirts pulled up, and you can see on the left, there's the opening of the feeding tube. On the right, this is at mealtime. You can basically attach a syringe, or even depending on the attachment, you can funnel in pureed or liquid items into the tube, and then you take it off and you put your shirt back on. And the main point is no one even knows you have a feeding tube between meals when you're not using it. We'll emphasize that again.
Brings up a question we have here. How long will a tube last before it will need to be replaced? And why does the balloon fail?
Yeah. Good question.
Good questions. Neither Dr. Harrell or myself are GI experts, and it's usually the GI doctor that puts the feeding tube in. Teresa might be able to chime in. I mean, the feeding tubes occasionally have to be replaced, and they usually have to be replaced, as Teresa mentioned, they get clogged. Sometimes the top of it comes off, but I don't know in terms of an average of when they need to be replaced in terms of a timeline. I'm not sure.
Okay, so the gentleman in the left picture there has what we call a low profile tube. It's like a button that goes up against the skin. That usually does not get put in as the first tube. That would be the second tube. And we recommend that patients don't switch out the tube for the first 12 weeks, kind of like just to get your body used to it, maybe form a little scar tissue so that when we switch it out, there's no incidence of, closing or anything like that. The balloons, they're just latex, and latex does not last forever. They have some fluid in it, but on the outside, within your stomach, there are hydrochloric acids and other acids that are swishing around. And over time, I guess those acids just bang up against that balloon and kind of, make that balloon break apart or thin out, and eventually it will get changed. We don't recommend that you get the tube changed on a scheduled basis. People have them for a year or two, they're fine. Other people get them, and you may see some gunky stuff inside the tube, or the food is sticking to the sides, the formula is sticking to the sides, and you may just want to change it because of the way it looks. But no changing before 12 weeks if possible.
And we'll talk a little bit about the procedure itself. When we're talking about changing, these are minor procedures, as we'll discuss. So if you don't have a feeding tube currently, and this was, I believe, the first question, when do you ideally place a feeding tube? And the answer is early, okay? Because the way you breathe affects how the feeding tube can be placed. And if your breathing is strong enough, doesn't have to be normal, it's quite easy to put in a feeding tube. If your breathing deteriorates to the point where it's hard for you to lie down flat, that makes inserting a feeding tube more difficult, and we'll talk about that. And again, just to really, really emphasize some main points, placing a feeding tube does not mean you can no longer eat by mouth. The goal is to continue trying to eat, or at the very least taste your favorite foods. You can put the tube in before you actually need it. You don't have to use it immediately. It can be placed prophylactically, and it's better that way to have it ready for when you need it. Okay.
But you would still have to flush it with water, at least once a day to keep it open and functioning. But as Dr. Hrell said, if you don't need it for nutritional support and you're able to maintain your weight and get all your nutrition by eating by mouth, then that's great.
And we do have a question about, again, back to the changing of the tube. Should that be done at the hospital or can it be done at home?
It's done by the doctor, at least in my experience, it's done by the doctor in a clinic or in a hospital.
The low profile button tubes are changed more frequently, and sometimes families are taught how to change them.
Okay.
Great. So how are these tubes placed? Many of you have had colonoscopies. It's not placed via the colon, so that's the good news. But those of you that have had colonoscopy, it's kind of a similar clinic-based procedure, an outpatient procedure usually, except it's from the mouth. Some of you, for other reasons, may have had something called an EGD, or endoscopy of the upper digestive tract. So I'll just show you a picture. You lie down flat, and this is in the office. It's not a operating room. It's in the clinic. You're usually given at least some light sedation, because it's still not pleasant to have a tube stuck down your mouth. But there is an endoscope that's threaded down the back of your mouth, and it can go all the way to your stomach while you're awake. Not quite as bad as it sounds. Okay. And I didn't ask Natalie beforehand, but I know I've had this done as a research procedure. It's not the best, but it's not the worst either. And then the cool part is really the next picture. You can shine a light from here, it goes all the way down the tube, and you see the light through the skin coming out, and that's when you know you're in the stomach. This is a safety feature. So you put your finger on the light and make sure that there's really only skin between the light and your finger and the person's stomach. And then you basically make a small hole into the skin, and you insert the tube, and then you inflate a balloon so that the tube doesn't just come popping right back out. This is all done relatively quickly as an outpatient procedure. Why does it need to be done early? It's all right here. Some of you have learned it gets harder to lie down flat as ALS progresses. And if you have trouble lying down flat, you're going to have trouble with this procedure. And that's a breathing problem. When you lie down flat, your diaphragm, which is kind of a little bit off the screen of this picture here, doesn't function quite as well as when you're sitting upright. So lying down flat makes it a little bit harder to breathe. And if it's too hard to breathe during this procedure, it can't be done in this way. Okay, so we advise getting this procedure done before your breathing becomes too much of a problem. However, it's still possible to do a feeding tube placement, even if your breathing makes it not possible to do it this way. However, then it might require, at least temporarily, putting you on a breathing tube or ventilator during the procedure, and then hopefully being able to remove the feeding tube after the procedure. But the risk is, if your breathing is not that strong to begin with and you're placed on a ventilator, even if only for a few hours, sometimes it's very difficult to wean back off of the ventilator. So we try to avoid waiting too long to have these feeding tubes placed. want to pause there and make sure that that makes sense and see if Natalie wants to add anything. People have any questions?
No, I think we're in agreement that earlier is better. But again, it's a discussion that you have with your family, with your physician, with the other team members that are treating you. But yeah, earlier is better.
And I apologize. I mean, this bears, it's worth saying, even though it's so, when we have these discussions with individual patients, we always make it up to you. It is completely up to you whether you want a feeding tube to begin with. And I'm sorry I did not lead off the whole conversation with that. When I say do it early, we're talking about for those of you who decide you want a feeding tube. We're just trying to give you more information about the feeding tube process and about the fact that it's actually not something where you're attached to an IV pole the rest of your life, and it's not something where you can't eat the rest of your life. So some people, once they hear those things, they're much more willing to undergo a feeding tube than they would have been otherwise. But it always remains your choice, and you will always get treated to the best of our ability within your choices. Okay, so any I must admit, I don't know the answer to this question about as the ALS progresses, how does changing the tube get harder? Does changing the tube get harder? Do you have to lie flat to change the tube? I don't know the answer to that. That's really what you're asking, I think.
No, you do not.
So once it's in there, changing the tube should hopefully not become harder even as the ALS progresses. Thank you.
Correct. The longer you have the tube, the better the tract is that's holding the tube in. So you have more scar tissue. And it's if you're out there and you have a pair of pierced ears, your earrings, you could take them out, switch them out to new ones. It's much easier after you've had the earrings for a while. Same thing with the feeding tube. Sometimes the tube gets dislodged, and we want you to get to the emergency room to get that tube put in as quick as possible, because it will start closing up quickly. But you do not need to be laying flat once you have a good tract.
You do not need to have your head shaved either for this procedure. Okay, so here we go. We want to repeat. Living with the feeding tube. You can continue to enjoy eating your favorite foods as safely as possible, but you will have less pressure to have every meal and every calorie and every gram of protein counted. And that can be a big relief to many people. And again, when you're not using the tube, no one even knows it's there. I admit we sometimes forget, or frankly, I often forget to examine the feeding tube when I'm seeing a patient, because I'm a neurologist and I'm really talking to them about other things, and I forget it's there because I don't see it under their shirt. Don't tell Dr. Galea I said that. Okay. All right.
We won't.
So she knows anyway. So when breathing gets tougher, let's talk more about the breathing. Very obviously, very important topic. What are the symptoms of your breathing getting harder? Of course, if you feel short of breath, that's a symptom. But there are other symptoms out there that you may not even realize are related to your diaphragm. And again, we emphasize difficulty lying flat. You may not feel short of breath lying flat. You just may not feel good. And people can often have a hard time describing it. But that, unfortunately, is probably a sign of weakness in your breathing muscles. Trouble lying flat is usually, in the case of ALS, weakness of your breathing muscles. Difficulty clearing phlegm out of your chest. Having trouble getting a full cough is another very common symptom. And Natalie, how about?
Yeah, so a weaker voice, because as many of you know, the possibility of your speech being affected by ALS is there. And so one of the common complaints I get from my patients with ALS is my wife can't hear me when she's in the other room, or people on the telephone have difficulty hearing me. I find that my voice gets much weaker. And the way we produce speech and our voice, the power of our voice comes from our lungs. Okay, so when we push the air out from our lungs, and there'll be a slide in a couple of slides where I'll show you exactly what happens. The air comes up from our lungs. We're exhaling the air. It goes up through our vocal cords or our voice box. They vibrate and sound is produced. So we can yell at a very loud voice by breathing in and pushing out that air strongly. So when our breathing is affected, it's going to possibly affect the strength of our voice as well. And so that could be a sign that, maybe my breathing, my inhalation and my exhalation, my breathing muscles aren't working as well as they did before. In addition, a lot of our patients complain of just getting tired during eating. Again, as I mentioned earlier, when we're eating and swallowing, we're really not giving it a second thought. But it's actually very taxing for a body, and for anybody really, to finish a meal. It takes a lot of energy. And part of that energy comes from our breathing. So it's very common to feel very tired during a meal and have difficulty completing a whole meal in one sitting. So a lot of times we recommend that the person kind of have small, frequent meals throughout the day because it just conserves that energy when eating.
And I threw in anxiety attacks because, of course, anxiety can come from many things, but believe it or not, subtle changes in your breathing pattern can trigger a reflex. It's not like I'm stressed out. It's just a reflex where you start feeling anxious. You don't even know why. It can be a symptom of breathing difficulties. Of course, it can be a symptom of many other things as well. Before we move on, Mary Rodriguez asked a really important question. If you choose not to get a feeding tube, what happens? So the answer is, first of all, I'll answer the last part first. The timetable is very variable. It's different in every single person. It depends how much you can eat and how much fluid or hydration you can achieve by mouth. But it's up to you. Some people continue to eat even when it's no longer safe for them to swallow safely. They said, well, I understand the risk. I'm going to keep eating. They may not lose weight as quickly, but they may get pneumonia more quickly, and that may unfortunately kill them. And other people will see, well, I don't want to take anything by mouth either. And so they won't get pneumonia necessarily, but they will lose weight and essentially starve. Now, one thing I want to say, and I would assume, I hope it was discussed in one of the other sessions with palliative care, there have been many studies on what happens when you decide not to get a feeding tube in various disorders. And many studies have shown that it's not as bad as it sounds. And I hate to put it that way because I'm not an expert on that topic, frankly. But it's not, there are studies that show that people who refuse feeding tubes don't suffer pain or other things as bad as you might expect. And of course, it's done in conjunction with palliative care team that can help address symptoms of hunger or breathing difficulties all along the way. So it remains your choice of whether to undergo procedures. It remains your choice of how to treat symptoms of not undergoing procedures. There's a lot of control out there with palliative care. I'm wondering what Natalie and Teresa.
Yep, and just to jump in, so if somebody chooses not to get a feeding tube and they've been evaluated by a speech pathologist and it's been determined that they're at risk for aspiration, so then we would work very closely with the person and their family and the dietitian to make sure that the person got the kind of biggest bang for their buck when eating by mouth, to make sure that they would eat those high protein foods that are so important, that would eat consistencies that are the safest for the person to swallow. For one person, it might be a pureed diet and maybe some thickened liquids. For another person, it might be just full liquids. For another person, it might just be softer solids. It really depends on the individual, and it would be based on an evaluation by the speech pathologist. But as Dr. Harrell said, it is a personal choice and an informed choice in terms of making some of these decisions regarding treatment, and feeding tube is one of those. And we would also work on taking medications by mouth. As Teresa mentioned earlier, one of the benefits of having a feeding tube is that it can make it easier to administer medication. But if a person chooses not to have a feeding tube and they still need to take their medications, then we would work with the pharmacist to make sure that medications could be crushed or could be put in liquid form, or sometimes just putting a pill in a teaspoon of applesauce or yogurt makes it much easier to swallow. So we would work together with the person to maximize their nutrition and trying to keep it as safe as possible.
And of course, we would have a longer discussion in person. It's hard to have the whole discussion right here, but that's a very important question. Thank you. Just add a couple of things here. Back to when breathing gets tougher. Some of you may be familiar with the term FVC, or forced vital capacity. We had mentioned that placing a feeding tube is more difficult when you have trouble lying flat. And really kind of a rule of thumb is if your FVC, or forced vital capacity, is less than 50%, that's around the time when the feeding tube procedure becomes more difficult and may require something a little more invasive than just an endoscopy. And remember, endoscopy is usually just an outpatient procedure. Okay, so let's move on. How do we treat breathing symptoms? We don't just go straight to a ventilator. Okay, there's many other options, and I'm sure many of you are familiar with what's on this list. Breath stacking. Basically, this is a way to help inflate your lungs, giving yourself an extra boost. If you're able to squeeze this bag with your own hands, you basically take a deep breath in, and then you add a little bit of extra air in on top of that. That helps keep your airways open. And you can either squeeze this bag, or a caregiver can squeeze the bag, either way. There's a machine that kind of essentially does the same thing for you, and I'm sure many of you are familiar with BiPAP. Okay, first of all, it's related to CPAP, which is something that's used for many other people who have sleep apnea. But BiPAP, basically, when you inhale, it basically adds some pressure to make it easier for you to inhale. And when you exhale, it adds a little pressure that prevents your breathing, your small breathing tubes from collapsing. Okay, and BiPAP can be applied either through a face mask like this, or through these, what are called nasal pillows, through a machine. That one looks a little big. There are smaller ones out there. And it basically can help you breathe, especially when you're lying down. Most people that use BiPAP start to use it at night while they sleep. It helps them sleep in a bed lying flat, and it helps them sleep better. It may require some tinkering with the type of face mask or nasal pillows to make it more comfortable, but usually people find that it's quite comfortable. And again, these are things that are all studied. We're not just saying this is not just our own opinion. These are studied. This improves survival and quality of life for people that use it. Not everyone likes it, but those that do use it usually are quite happy with it.
And with the BiPAP, as you can see in the picture, as Dr. Earl said, they have nasal pillows. So that's where the airflow is going. You can also have it with a mask, a full mask or a half mask. But the benefit of the nasal pillows, it allows you to continue talking, okay, and allows you to continue to eat, which is another topic with using the BiPAP. But you're still able to eat by mouth with the BiPAP. Most importantly, you're still able to speak, especially when you wear the nasal pillows.
Another great question just came in. We'll get to that in one moment. I just want to add one other thing. Along with BiPAP, this came up earlier, is as your breathing gets a little bit harder, it becomes harder to clear your chest of secretions like phlegm. And there's a device called Cough Assist device that its name is a little bit misleading. It's not something you just slap on when you need to cough. It's something that you want to use a couple of times a day to try to keep your chest clear. It basically says, okay, it's time to cough. Let's use the Cough Assist device in the morning and at night, and we'll cough on purpose to get our chest clear. And it's basically a device that helps increase the pressure to make your diaphragm go poof and cough out a bunch of phlegm. During the time of COVID, that may be more of an issue, but as long as you're with a caregiver and you're both protected, this helps clear your chest and prevent things like pneumonia from setting in.
And that's
Whoops, go ahead, Natalie. Go ahead.
Sorry, I was just going to say, a lot of our patients complain of the sensation of extra phlegm and secretions in their throats. And they think, well, maybe if they can take like over the counter, like Mucinex to kind of dry up the mucus. Sometimes that helps, but it's not so much that your body is producing more phlegm and more mucus and more secretions. It's just that your body is not as efficient as clearing it and coughing it and getting it out. So that's why the Cough Assist is a huge help, because it helps assist the natural, as I mentioned earlier, reflex that your body has to protect its lungs by coughing. So a lot of our patients like using it, and it's very effective.
And a lot of people say to me, well, the Cough Assist isn't helping. Nothing comes up. You don't always have to have something come up. I'm going to cough right now, taking a deep breath in and then forcing a lot of air out. Nothing came up, but I hyperinflated my lungs and I got the lungs full of air for that second. And that's what the Cough Assist does. Keeps those lungs maximized.
It's like keeping your car tuned. It's
Well
prevented.
tuned, yep.
Definitely. And this kind of dovetails with the question that just came in, extreme salivation. So as Natalie just said, unless you're dehydrated, we're actually all salivating most of the time, but we hardly notice it because we're swallowing okay. As swallowing becomes more difficult, that's when saliva and drooling becomes a huge problem. And unfortunately, this may contribute, you're right, this contributes to the problem of lying flat. It's not just breathing weakness. It can be that there's too much saliva pouring down the throat when you're lying flat. And we see this all the time.
Yeah, and a lot of our patients complain, especially, in the middle of the night, if they're lying flat, they're woken up because they're coughing and they have to cough up the saliva, or they wake up in the morning and their pillow is wet from saliva coming from their mouth. And again, it's not so much that the body is producing more saliva, it's just our body is not as efficient as managing it. And we swallow multiple times during the day without us even being aware of it, and we're swallowing our saliva. But with this diagnosis of ALS, that ability to remove the saliva and manage it efficiently is not as good.
And there are medications for that, and they each have pros and cons, but we have multiple different ways, including if the pills don't work to treat that, believe it or not, Botox can help for that. And I don't know if any of you out there have had Botox injections into the salivary glands, can slow down the saliva process, the drooling process. But of course, we try pills first. So there are treatments for that.
And we try not to put the Botox in until you have a feeding tube because it can alter your swallowing. Yeah. So we want to make sure you can swallow, get nutrients in.
Get enough nutrition, yeah.
There's a catch to everything, unfortunately, yes.
We do have a question actually about the Cough Assist while also using a feeding pump and worried about vomiting.
Natalie, are you aware of anyone on a continuous feed?
Good question. Yeah, it really depends on the type of tube feeding. So you can have continuous, you can have bolus feeds. Yeah, I'm not quite sure. I don't think, and Teresa, you're probably better able to answer this in terms of the negative impact of using the cough assist. I mean, I guess my recommendation would be to, stop the feeding at that time that you're using the cough assist. But Teresa, maybe you're better able to answer that.
Right. We don't want anybody using the cough assist if they're eating. We want them to give like a half an hour to 40-minute post eating to use the cough assist. So if you're going to use a scheduled cough assist, then you're going to wait a little bit. Same thing here. You would pause the pump for a good probably 45 minutes to an hour, because if you're using a pump, that means you're probably slower at ingesting the formula. And so we want to put a pause on that. But if there's an urgent need where you feel like you're coughing and you can't move something out and the cough assist might help, then by all means, yes, go ahead and do that. The risk of vomiting is not that great.
Great. Please keep the questions coming. So again, we were just talking about non-invasive assistance for breathing. And of course, there's an option to go with an invasive form of breathing help. And it's also a way to keep your airways clear of various types of secretions. So it's called tracheostomy. Maybe, Natalie, I'll put you on the spot.
Sure. This is just a picture of what a tracheostomy tube might look like. Okay. And we'll have a better slide in a couple of slides to show you exactly how it is placed. But and you can use a tracheostomy without being on a ventilator. Okay. So let's go to the next slide, Noam. So with a tracheostomy, yeah, why don't we go to this one and then we'll go back to the other one. So this is kind of, and I got to put on my reading glasses so I can see it. So this gives you an idea of where the tracheostomy is placed. So since you guys can't see my cursor, right. So there's the tracheostomy tube and a hole is placed in your neck, and the tube is placed through that hole and goes right into your airway. So you're breathing in and out through that tube, okay? No air is going up through those vocal cords. And Noam, if you can just highlight the vocal cords there, which is your larynx or your voice box, okay? And so with the tracheostomy tube, no air is going between your lungs and up through your vocal cords and through your mouth. You're breathing in and out through that tracheostomy tube. Okay, so if you were lying flat, like the letter B there, all you would see a little bit of a trach hub or a little bit of it coming out, okay, and it's held onto your neck with just a trach tie, okay, it's fairly comfortable, but it goes into your airway. So let's go back to the previous slide. So a big question I get is, can I speak and can I eat if I have a tracheostomy tube? And the answer to that is usually yes, you can. So as I mentioned, the placement of the trach tube causes a disconnect between your upper airway, okay, your throat up here above the level of your vocal cords, and your lower airway, your airway going into your lungs, okay? And so that's going to absolutely disrupt your ability to speak the way you usually speak and swallow the way you usually swallow. But there are ways around it. And one of them is called a speaking valve, okay? And the speaking valve, so if we go to the next slide, no. Okay, so this is what speaking valves look like. This is just one example. I'm not advocating for Pasteur, but it's one of the ones that's more commonly used and known. And so the speaking valve, the purple one that you see there, goes on the outside of that tracheostomy tube. And all it does is redirect the air coming from your lungs. So instead of going out through the tracheostomy tube, it's redirected up through your vocal cords, out through your mouth and you talk like you normally talk.
So it's
Okay.
bypassing this balloon, Natalie, right?
Well, the balloon has to be completely deflated. The balloon has to be completely deflated. Now, not to get too technical with you, there are two types of trach tubes. One has a balloon, okay, that is inflated, and that is the trach tube that is used if you're on a ventilator. The other trach tube is something called a cuffless trach tube. It does not have a balloon. So imagine the same picture you're looking at in figure A, but without the balloon. So when you use the speaking valve, you use it with a trach tube that has no balloon, or that balloon is deflated to allow the air to go up around that trach tube and up through the vocal cords. Okay, so the purple one would go just on the outside of the trach tube. Okay, the blue one that you see there actually goes in the tubing if you're on a ventilator, and we have a picture of that as well. So with using the, yep, right there. So right there, you see that blue speaking valve, okay? And this is a person who is on a ventilator. You see the ventilator in the back there, and the nurse or the speech pathologist is feeding the patient, and they're still on the ventilator. So the ventilator is breathing for this person, but they have the speaking valve on, which kind of normalizes the breathing and the swallowing process. All right, so to answer the original question back a couple of slides is, can I speak, can I eat? Again, working with a speech pathologist, working with a respiratory therapist, working with your physician, the goal is absolutely you'll be able to speak and be able to swallow using one of these speaking valves.
I think that's a good point to bring up. A question that I'm sure lots of folks are asking is, at what point is this required? And how would family members know if it's time?
Really good question. Really good question. And it would go back to the, first of all, informed choice and having these discussions with your providers about goals of care. Okay. And what is it that I want going forward? Okay. So that's number one. But if the choice is to pursue a tracheostomy tube and possibly pursue mechanical ventilation, it would be based on those breathing function tests that Dr. Harrell had mentioned, the symptoms that the person was complaining of, you know, difficulty lying flat, difficulty breathing, just not being able to breathe, getting very winded and short of breath when walking, when talking. Another thing to consider is secretions. When somebody has a tracheostomy tube, the person can be suctioned and those secretions can be pulled out through the tracheostomy tube. So if a person has a lot of difficulty managing their secretions, then that could be an indication that maybe a tracheostomy tube would be appropriate if their airway was going to be compromised.
And
A good thing, can I just jump in here for a second? If
Sure.
the patient was not able to speak before getting the trach and a person passing Muir valve is not going to help them speak. And if
Okay.
they were not able to swallow before having the trach is not going to help them swallow. I just want to clarify that.
Correct, correct, correct.
and there's another great question. We will definitely get to that in just a couple of slides. These are complex and intensive interventions. But to continue the point about the question, when is a tracheostomy required? First of all, it's never required. It's an option. Second of all, of course, we try as best as possible to use every form of non-invasive treatment first. But then it's a very difficult choice that requires a long conversation with the entire team with Natalie or your speech and language pathologist, with your neurologist, with your pulmonologist, and very, very importantly, with your palliative care coordinator or physician to discuss. There's a lot of variables to consider about when or if to get tracheostomy.
And as I mentioned yesterday in the presentation about the multidisciplinary team, there's always a member of the care team, like the coordinator usually stays in touch with the patient in between time. So if you walk out of the office and that question was asked and you weren't ready to answer it, you can always reach out. The care coordinator will either help you or get you in touch with the people you need to speak with in between. You don't have to wait between one appointment and another.
Right.
And another great resource is ALSA and just patient advocacy groups, and speaking with other patients and other caregivers of those patients is obviously a great resource, and hopefully these types of meetings lead to more of that. Okay, let's move.
Yep. So just briefly, because I think there was another session led by a speech pathologist talking possibly about other ways of communicating. So we already spoke about a speaking valve, but just through the course of having a diagnosis of ALS, the speech, swallowing, and voice can become affected, as we've already spoken about. So there are other options. We call them alternate or augmentative communication options, simple writing. Big advocate of the boogie board. If people can still write, sometimes it makes it a little easier to get across what you want to say quickly. Using your smartphone, using an iPad. There are a lot of text to speech apps if the person still is able to type that allows them to help with the communication. If a person is on a vent and still has use of their hands and can still type, they could absolutely use a text-to-speech app. And then the two pictures there on the slide are examples of speech generating devices that are computers that have specific communication software installed in them, and they can be accessed by using your fingers, direct selection, or using a head mouse or an eye gaze. And I think this might have already been discussed in one of the previous sessions, but I just wanted to let you know that there are always other options of communicating if one cannot speak verbally. So that was it on that slide. Oh, and voice banking. Thanks. Didn't realize that was still hanging out there. So voice banking is something that we advocate doing sooner rather than later because it gives the opportunity for the person to actually record messages and using their own voice. And then it's kind of stored in a bank. It's actually a file. And then if the person would need a speech generating device down the road, they would be able to use their own voice to say the messages and to communicate what they needed. So that voice banking, those messages that you saved in that file can be transferred to the speech generating device. And so instead of having a voice like Siri coming out of the speech generating device, it could be your voice with those messages that you had recorded earlier on. So that's something called voice banking.
And speaking of devices that you're speaking about, so there's a question about the cost of them. Maybe Teresa wants to talk a little bit about the equipment loan program, if possible.
Okay, so first of all, to answer the question, the devices are considered a durable medical equipment. You wouldn't be getting those devices unless you had a medical need. So your insurance company pays for 80% of the device, and then you or your secondary insurance would have to pay the leftover amount. The veterans have a different system, so it's probably better for me to answer that question. And if we do have an equipment loan program at the ALS Greater New York chapter, and we do have speaking augmentative communication devices in the loan closet that we could loan out to the patients based on their capabilities. Some of them are more higher tech and some of them are less techy. And patients have all different devices they can choose from. And they would have to reach out to our team at the office, the assistive technology and equipment loan team. Was that the only question? I guess so. Why does it cost so much? You have to ask your congressman. I have no idea why it costs so much.
It's very, yeah, Medicare will cover, and insurance companies will cover the cost of a speech generating device, which is very, very expensive, especially with eye gaze. It can cost close to $15,000. But an iPad that costs what, a few $100s, Medicare will not cover unless they've changed it, because it's not a dedicated communication device. But there are many text-to-speech apps that are available that can be used on an iPad or a Samsung tablet that are pretty good. And actually, the iPad and Apple are working on an eye gaze system to be used with smartphones and with tablets.
That program was developed by some technicians at the Stony Brook University, and they're actually testing them on our patients at the Stony Brook Clinic right now.
Great.
And that would be, you would purchase an iPad and the app would be added for free.
Wow.
Which is excellent. Yeah, we hope that's just around the corner.
Terrific.
But just to keep on this issue here of some of the technology, there's a question about a voice banking company, which I'm guessing there might be several options and not just one for that.
Yeah, there are. The one that's the most popular that I'm aware of, and again, there are many out there, and again, not to say one is better than the other, but Acapella is a company that the person signs on, establishes an account. There's a little bit of a training module that you go through, and then you're allowed to bank those messages. And I believe there is a cost when those messages are taken out of the bank and put into one of the speech generating devices. There was also another company called Model, Model, Talker, which is also another voice banking program. And again, we can't advocate, one versus the other, but those are a couple of options that are out there.
Just to add a point or two, why is it so expensive? Part of the reason is, unfortunately, the way the healthcare system works and the insurance market works. It's not really real costs. As you can see, an iPad can do stuff that a $15,000 machine can cost, but insurance doesn't cover the iPad. It's just a weird system we have, unfortunately.
Yeah, as Teresa said, our Congress people and in the government, yeah, it's all
so well.
Yeah.
Anyway, another great question is coming up. Let's get to it right in a minute, please.
So that was it for this slide.
Yeah. So.
And we kind of already went over this. Yep. So let's move to challenges.
I'm just going to list them. Sorry about the, okay. So unfortunately, there's no cure yet for ALS. Everything has a catch, okay? So, and this is partly will also address the last one. The question that just came in is, if you have bulbar symptoms, meaning trouble swallowing, trouble speaking, and yes, trouble breathing, will a feeding tube help you live longer than those who choose not to? The short answer is yes. Feeding tubes increase survival, without a doubt. And actually, the second part is actually an easy answer, and I want to make sure that the doctor should, if you're losing weight and you're not consuming enough calories, absolutely yes, the doctor should bring up the option or the discussion of a feeding tube. And it's unfortunate if the doctor didn't bring it up, And it's unfortunate to say this, but the squeaky wheel gets the oil. So you should absolutely advocate as much as possible for yourself, and caregivers should advocate as much as possible for their loved ones. But this is a discussion that should come up, and it's more likely to come up at a multidisciplinary clinic than it will under one single clinician. It's just inevitable that a multidisciplinary clinic will be more aggressive about bringing up all these options because it's multiple disciplines.
Yeah, chances are the dietitian may bring it up much earlier than the doctor may bring it up because they'll notice the weight loss.
Weight loss, yep.
And they'll also be possibly in the room with the speech therapist at the time that they do a little swallow eval, and they'll see how difficult it is for that fluid or the applesauce to go down. And the dietitian may bring it up right at that point.
Yeah.
Great. And actually, I believe the next, yeah, so there's definitely evidence of this, and we can send out more afterwards for Julia Yasik. So just a few points. Feeding tubes, non-invasive ventilation, invasive ventilation, they do increase survival, but there's always catches there. So to take care of a trach, it's a lot of caregiving needs. And that's an issue to discuss with yourself and with your family. What are your goals? What are your concerns? You know, do you have things that you want to see or milestones you want to see in this short-term or medium-term future that make some of the challenges worthwhile? But there's high caregiving needs for trachs and for ventilators. There's a lot of cost. Homes sometimes need to be renovated. Transportation becomes more difficult when you're attached to a ventilator, of course. Although, of course, there are also many ventilators that are made to be transported. So it's not the same thing as a hospital ventilator. But in some cases, it just becomes too hard to live at home with all this equipment. And in some cases, it may require living in a facility. So that's part of the variables that you have to discuss as far as determining your goals and needs and your family's values, etc.
In the last couple of years, people have not been discharged from a rehab facility after they've gotten the trach unless the family can prove that they have a generator. Because when somebody is dependent on a ventilator, if there's a power failure, that's a big problem.
Yep. Very good point.
And I didn't see stats on this, but you wonder what happened in Texas a month or two ago. We all know what happened in New Orleans 15 years ago. That was terrible. But even in Texas, I'm wondering, with all the power outages they had, that may have been a major problem. We haven't mentioned this all day. Let's mention it. DNR, DNI. This is a topic that many times is awkward to bring up, but it needs to be discussed. Do you want to be resuscitated? Do you want to be on a ventilator if that situation arises? These are things that are best discussed ahead of time. You don't wait until it happens to discuss it. And think about the family. If these wishes are clearly indicated ahead of time, then a family member may feel less pressured or less guilty if they follow through a pre-stated direction than if they try to decide what you would have wanted otherwise. I hope I'm not being too blunt about that. What do Teresa or Natalie have to say about that?
Yeah, I think, I think the key is early discussions, making informed choices, gathering as much information, asking questions, starting the conversation early. And I know it's difficult. It's difficult to talk about these things. But I think based on my experience with our patients here, it's important to think about it and to, again, ask questions. Nothing has to be decided at that moment in time, but just ask a question, broach the subject. Let's have a little conversation about it, just to kind of get the wheels thinking and turning in what direction I might want to head in.
When we talk about this at support groups, if it just comes up, haphazardly, I always make the point that anyone over the age of 18 should have their decisions made, because you could be in a car accident and the doctors are going to intubate you, and then you end up like a Karen Quinlan or something like that, and your family is fighting over what to do and what not to do. So it's not just because you have ALS that you should have this open discussion with your family. It's because you're living and nobody gets out of here alive. And sometimes there are emergent situations and you won't know what to do. I myself have my healthcare proxy on a magnet on the refrigerator door, and I've discussed it over and over again with my husband. And as my children got older, I explained to them what I told my husband I did and did not want to have done, so that they don't get mad at him for doing or not doing something.
Right.
And that's the way the family conversation should be. Siblings of the patient, children, or parents of the patient should all understand what the patient's wishes are.
Right. And just piggyback on that, because at the end of the day, it should be your choice. It should be your decision. And sometimes for family members, that makes it easier when they know that, oh, Uncle Joe wants this, this, and this. It kind of takes the pressure off of them. But having those discussions early on and talking about it, nobody likes to talk about it, but don't have to decide it all right then and there. It's over a period of time, but it's good to do it early.
It's not like buying a plane ticket. You can change your mind at any time. One or two good things that came out of COVID is now we can change our mind about plane tickets, I guess. But we see people change their mind. Yes, I do want certain interventions, or no, I don't want. And they change their mind multiple times. That's fine. That's fine. This is not an airline.
Right.
I've also seen a lot of patients who have gotten a feeding tube and never used it. They got it because we advised them, and then they decided they didn't want to use it, and they don't. Things
And
like
how
that.
many of them really regret it, though? I mean, it's not.
Yeah.
I would assume not many at all.
The ones who don't get it regret it. The ones who get it, usually are pretty happy about it.
Right. But again, it's a choice. And as Dr. Harrell says, you can change your mind. So it's not like it's written in stone. So it's important to keep those discussions going, because things change, people change, thought processes change, and who they speak to, and asking questions and getting an answer here versus there. So the discussion should be ongoing. It doesn't necessarily have to be a one and done, and that's it.
There's another question here about how early should someone get a non-invasive ventilator. So at the ALS centers around the tri-state area, we have pulmonary function testing that's done right now during COVID. Maybe they're not doing them the same as they used to, but that's part of the team's way to evaluate the patient's decline in respiratory status. And we can offer non-invasive ventilation earlier. The sooner you get it, the easier it is for you to get used to it. When you're not gasping for air and have to put a mask on your face, when you're sitting watching TV and can put it on and get used to it, it's better to acclimate yourself earlier and then work your way up to needing it longer. So as soon as the doctor can get it, I think the patient should get it. That's my opinion. I don't know how you guys feel.
That reminds me of something. I think we all just know this because we're doing this a lot. When you get a non-invasive ventilator, it's not 24/7. People usually use it only for, let's say, a few hours a day, and not even every day at first. As Teresa just said, you get it and you just get used to using it at certain times of the day or night. It is not something where you make a decision and then you're on 24/7 on a non-invasive ventilator. So these are more reasons why, if you choose to do these things, we do advocate to do it earlier rather than later.
All right, folks, we have about 5 or 6 minutes left. If you want to get any last questions in before we end our session, there will be a session at 3:45 for a wrap up for the afternoon, when you can have all of your questions asked by or answered by our chapter staff. I do have one question here that's that I don't think anyone raised so far, which is, what should I use to clear a patient's nose, for example, during allergy season? Any solutions on this one?
So to clear because the patient has
Runny nose.
runny nose or stuffed nose.
Mm-hmm.
Wow. I usually refer to ENT for this. Yeah, I'm not sure what I would recommend. Obviously, if they're seasonal allergies and if they haven't been seen by an allergist, maybe try some over-the-counter medications, but I would only do that clearing it with, their primary care doctor. I don't know, Teresa, do you have anything?
I would
Well,
like to add as a victim, absolutely, I would start with over the counter, and I see Mr. Lunsford Stevens, Allegra, loratadine, cetirizine, all these over the counter allergy medicines do help. And if it gets bad enough, there are suction devices, and this applies to a question that came up earlier about drooling and secretions. There are suction devices that just you can wave around in the mouth. I'm not sure that's really as good for the nose, though.
yeah, we recommend saline sprays on a regular basis. And if it's a stuffy nose, we like to put a humidifier in the room with the patient.
Mhm.
And the suction is really for the
mouth.
mouth. Yeah.
Typing a few more options there. What other questions are out there? Thank you for these specific recommendations.
Yeah, that does work. Those little suckers, they do work.
All right, were there any slides left? Anything left to go over today?
Nope, I think that was it.
All right, well, if we don't have any last questions, I think we have just about ended this particular session. I'm not seeing anything else come in at the moment.
One more. It's like
So we do have a question coming in, it appears.
while that question is being typed in, again, this type of forum is really great, and I think if there are, and usually there are opportunities to join patient support groups and caregiver support groups, those forums are great places to trade questions and information.
Yeah.
Especially about things like the Frida baby snot sucker. I must admit, never heard of it, and now I have.
I have, yeah. Some people have used it, yeah. Good with babies.
We have a comment. Thank you all. Very helpful.
Good, you're welcome. We were very, very pleased to be part of this. Thank you.
And like we said, if there was a question over the last 3 days that you thought about maybe after this session, that'll be
Sadia,
happening at 3:45.
Sadia, do you have your one question?
Yeah, it just came in. So after using the cough assist, Sadia's mom still feels it stuck in her throat and there's gurgling. If she turns up the strength of the cough assist, it feels like it's hitting her chest. So it's either too weak or too strong on the cough assist settings.
And do you have suction? Because if you have suction, after you've used the cough assist, you can put the suction towards the back of the mouth, have her close her lips, and that should be able to pull the stuff that's at the top there.
Yeah.
And it might just be too thick, and you might have to use a humidifier in the room around her to keep the mucus thinner.
And make sure you stay hydrated, either by mouth or through the feeding tube, because the hydration will also help thin thick secretions, staying hydrated with water, drinking water.
She's saying she doesn't have suction, and I'm trying to type in an answer. She's saying it's too thick. But again, the cough assist helps bring it up from the lower chest to the mouth or throat areas, and hopefully we can get it to the point where it's thin enough that then some suction or yank hour type of device can pull it out.
All right, it is 3:30. Our session must end now. So thank you all. Thank to our speakers. Thank you, Teresa, Natalie, and Noam. And we will, if you have any outstanding questions, join us at 3:45. Thank you so much.